times. And if we need to ask questions during question time, please just raise the electronic hand and it will be recognized. And you can decide to put your questions in the chat box. And for those who may not be able to link up with us on this Zoom platform, because we have a limited space of 100, they can join us live on our YouTube platform, which is available. And that link has been shared on our Zap platform. We can share with others. So that's what we're going to do this afternoon. So before we progress, we should remember that obesity generally, the prevalence of obesity in Nigeria, according to a study done by Ramalan et al., was put at 15%. And while overweight is about 26%. So this is part of what we're likely to look at. How do we reduce the burden of obesity? How do we tackle the drivers of obesity in our society? So this afternoon, I will take this opportunity to call on our president, Professor Andrew Loko, to give us an opening remark.
Thank you very much, Dr. Olopade, for the kind introduction. Good afternoon, good evening, distinguished colleagues, ladies and gentlemen. It is our pleasure to host this very important program on this World Obesity Day. The Endocrine and Metabolism Society of Nigeria, as you know, takes care of persons with endocrine metabolic disorders. We undertake clinical practice, research, teaching, training of endocrinologists, and over the past so many years, I think we are much more than 4 decades now of existence as a society, a professional society. We have contributed substantially to the production of medical specialists in endocrinology, diabetes, and metabolism. Our products are within Nigeria and beyond, and we are proud to say that we pioneer and direct all endocrine-related activities in the country. It is our pleasure to host you this afternoon on this special World Obesity Day. We are going to be listening to lectures from seasoned scholars on the subject, and we implore you to please pay rapt attention during the course of their presentations, and then make useful contributions during the Q&A. We know that obesity, overweight is a raging health problem, and the statistics are not looking any good. But we are hoping that at the end of this discussion today, we are going to have good head starts as to how to manage our patients with obesity. It is my pleasure on behalf of the leadership of the Endocrine Metabolism Society of Nigeria to welcome you to this meeting and to thank all the organizers and particularly the faculty that is going to deliver on this topic today. Thank you very much, and I wish you all the best. We will convene again after the presentations have been taken. So thank you very much. You're welcome.
Thank you, Mr. President, for the opening remark. We should remember today is March 4, and it has been designated by World Health Organization as World Obesity Day. And this is a global initiative focused in promoting health and raising awareness around the challenges of obesity. So Professor Babatope Kolawole to give his speech briefly.
Thank you very much, SG. Let me also acknowledge the president of the Endocrine and Metabolism Society of Nigeria, our own Professor Andrew Loko, the eminent scholars that have been called upon to address the subject of obesity this afternoon, other members of EMSON who have joined the call, distinguished senior colleagues and colleagues. Let me first off say congratulations and kudos to EMSON for considering it worthy to mark the World Obesity Day 2025 in this way. This is remarkable in that we are living out the societal expectations of us as an important society, not only researching, but mitigating the challenges posed by endocrine diseases in general, and not just diabetes alone. So this is really commendable. It will be understatement to again go over the implications of not just health, but societal, economic implications of being obese, the implications on every facet of health, livelihood, economic implications, and all. The list just goes on and on. And for this reason, and the comorbidities associated with obesity, it makes it a very, very, very important illness that societies, governments, academia, everybody pay attention to. What you are doing today, I believe it's our own modest contribution to mitigating the scourge of obesity. I'm quite impressed by the area of speakers, eminent scholars on their own, whom EMSON have assembled today to address this subject. And I believe we will all be thoroughly educated. And I think the bigger message is that whatever we've learned, whatever the learnings, we also should then replicate this in our own small silos as we also join the vanguard and against obesity in our nation and in our society. Reiterating my president, I also want to urge us to listen with keen attention. I believe time has been reserved for discussion at the end, so where we can interact and ask questions of the presenters. So once more, I welcome us all to this important webinar, which and I hopefully also desire that this will be a recurring thing that we'll be doing every year. Congratulations to the organizers, the LOC, and then welcome everybody. Thank you so much, and God bless.
Thank you, sir, for the speech, sir. So this afternoon we'll be going on to listen to the first speaker, and that will be Dr. Uriwole Ojo. She's a consultant pediatric endocrinologist. And the topic she'll be treating this afternoon is healthy choices, healthier system, healthier lives. I will want to encourage her to start sharing her screen. While sharing her screen, I will want to take a brief citation of Dr. Uriwole Ojo. She's Folakemi Oluwatoyin Uriwole Ojo. She's a consultant pediatric endocrinologist. She had a bachelor's degree in medicine and surgery and master's degree in clinical pathology, both obtained from the College of Medicine, University of Lagos. She's a fellow of the West African College of Physicians, Pediatrics, and a fellow of the European Society for Pediatric and Adolescent Endocrinology. She started her career as a pediatric endocrinologist at Massey Street Children's Hospital, where she established the endocrine unit of the hospital, which presently is one of the training outlets for the pediatric and Adolescent Endocrine Training Center for West Africa. She rose to the position of the Medical Director and Chief Executive Officer of Mercy Street Children's Hospital before she was transferred to her current position as the Medical Director and Chief Executive Officer of Ebute Metta General Hospital. She's also an adjunct lecturer of the Eko University of Medicine, where she teaches medical students pediatric endocrinology. She's happily married and blessed with children. Let us welcome Dr. Iriwole Ojo to start with the first lecture. Dr. Iriwole Ojo, you have the floor for the next 15 minutes.
All right. Thank you so much. Good afternoon, honorable ladies and gentlemen. I acknowledge the already established protocol. The topic before me is healthy choices, healthy systems, healthier lives. And my name is Folakemi Iriwole Ojo. My outline is as follows. By way of introduction, in the past, management of obesity was individualized with emphasis on the sufferers. Causative factors of obesity are not limited to the individual. The systems where the individuals exist have an impact on the causation of obesity. Therefore, in managing obesity, the individual and the systems must be addressed. Key facts about childhood obesity. Childhood obesity is defined as a condition in which a child is significantly overweight for his age and height, for his or her age and height. The presence of excess body fat in a child significant enough to impair health and well-being. Diagnosis of childhood obesity is by measurement of weight and height, generating a BMI score by calculating the weight in kilograms over the height in meters squared, and plotting it on a standardized BMI centile chart. Any value equal to above the 95th percentile for age and gender is known as obesity in that child. Other clinical diagnostic parameters are weight-hip ratio, weight for height ratio, and the skin fold thickness. Childhood obesity can be classified into primary obesity and secondary obesity. The risk factors for primary obesity includes unhealthy food choices, lack of sufficient physical activities, family eating habits, genetics, and socioeconomic class. While secondary obesity is due to an underlying medical conditions such as genetic syndromes, CNS diseases, endocrine disorders, and medications. All of these can cause secondary obesity. More key facts about childhood obesity. Childhood obesity is constituting a major public health crisis at the moment on account of its increasing prevalence observed in several studies. Studies in the USA, studies in Nigeria, studies in Lagos, studies in Oshodi in Lagos, all showing that there's an increasing prevalence ranging from 3.7 in year 2001 to 8.9% in 2019 to 12.5% in 2015 and 10.2% in 2021. WHO says that childhood obesity is expected to increase by 100% between year 2020 and year 2035. It is known that 55% of obese children and 80% of obese adolescents will end up becoming obese adults. Obesity in childhood is linked to a higher risk of developing non-communicable diseases like diabetes and cardiovascular diseases in adulthood. The long-term consequences of childhood obesity includes disabilities, reduced quality of life, and ultimately reduced lifespan. Childhood obesity is associated with a lot of complications affecting almost all systems of the body. The respiratory system, the neurological system, the musculoskeletal system, dermatological system, endocrine system, the renal system, the digestive system, the cardiovascular system, and the psychosocial system. A study was done using cases that presented in a general hospital, that's the Massey Street Children's Hospital, over a 5-year period. And the children that presented in the endocrine clinic that had childhood obesity, the comorbidities were analyzed, and it was observed that almost all the systems were affected. Top on the list was 17.7% of the patients had pre-diabetes, evidenced by raised HbA1c levels. They also had skin evidences of insulin resistance, shown as acanthosis nigricans, which we can see in the picture in this slide, whereby there's dark velvety skin coloration on the neck and the axilla. Other psychosocial complications that could lead to poor school performance includes the children being teased, being bullied, having low self-esteem, going into depression and anxiety, which are very much undesirable in the children. Today being World Obesity Day, the theme is changing systems that can lead to healthier lives. Our focus is to make healthy choices and have healthy systems in place so as to achieve healthier lives. This slide shows somebody trying to make a choice. Do I go to the right or to the left? Here is a plate on the right-hand side and a plate on the left-hand side. Which one do we choose? Which one do we choose for the children? Is it the healthy plate that has vegetables, protein, and carbohydrate in moderate proportions? Or do you go for the fast foods on the right-hand side? How do our children spend their leisure time? These are choices that we make all the time. Do they spend their leisure time with engaging in exercises, physical activities, or do they spend long hours watching the television, increasing the screen time and watching video games? What is the role of the system in achieving healthier lives? The systems that we are going to address very briefly are the health systems, the government systems, the food systems, the media, and the environment. The healthcare system in Nigeria, there are limited number of medical healthcare workers generally because of the well-known JAPA system. And so that is affecting the healthcare delivery all over the nation. There is failure to identify childhood obesity as a disease. Most patients will have missed opportunities because some people don't even know that childhood obesity comes with its consequences. And so there is a need to increase awareness of childhood obesity and its consequences. There is a need for training of all healthcare workers in the identification and management of childhood obesity. Emphasis on school health program is paramount, as this is where these children are. This is where the cases are, and they are not identified and often missed. They should not be missed. The government systems and the policies. School health programs should be promoted. Advocacy and funding for the management of childhood obesity is required. Social welfare support is required because these children are often teased, they are often bullied. They often have poor school performance, even though they have the ability. But because they have that psychosocial complication, they don't perform optimally. There should be emphasis on child protection laws. The infrastructural enforcement in schools and communities to ensure the preservation of parks and walkways for sports and recreational activities should be enacted. This slide is showing two schools. The school on the left-hand side has a very large playground, a large compound where children can play. But on the right-hand side, you can see that the fence of the school is closely opposed to the school, limiting activities, physical activities of school children. The food system. A food system includes all processes and infrastructure involved in producing food. The growing, the harvesting, the processing, packaging, transporting, marketing, consuming, distribution, and disposing of food is all that occurs in food system. The food system could be classified into non-processed, minimally processed, moderately processed, and highly processed foods. But it's sad to say that a lot of children are given highly processed food, especially when they're going to school. On the right-hand side, we have the highly processed food, the fast foods, the likes of the burgers, potato chips, donuts, sweets. But on the left-hand side, we have the non-processed foods, straight from the farm, the likes of vegetables, carrots, beans, and the rest of them. We need to make choices, right choices for our children. Poor food systems can lead to unhealthy diets. Unhealthy diets contribute to increased rate of obesity. The recommendation is to reduce the consumption of highly processed foods and to bring the consumers as close as possible to the producers. The media, what are we doing about the media? Restriction laws guiding advertisements, especially advertisements of highly processed foods, should come with announcements of the risk of the consumption of these foods. Just like the cigarettes, advertisement of the cigarettes is a must that they must announce that smoking is dangerous to the health. So should advertisement of highly processed food. That's what should come with it. The risk of its consumption should go along with the advertisement. The health-related and radio and television jingles should be encouraged. There should be an increase in health-related television and radio programs. Role model participation in the fight against obesity should be projected on the media, such as celebrities' participation in sports and outdoor exercises. We all know that our children and our youths, our adolescents, they idolize celebrities. And so celebrities should come out and participate in outdoor programs, outdoor sports and exercises. And then the media should project these people so that our youths will take to their advice. Look at the environment. These two pictures are taken from different parts of Lagos. The part on the right-hand side, we all know these parts in Lagos, and the picture on the left-hand side. But we can see that one environment is sports and outdoor exercise unfriendly, whereas one of the pictures here, still in Lagos, is sports and outdoor exercise friendly. And so our environment needs to be outdoor exercise friendly so that we can take walks, so that we can participate in physical activity without fear of being knocked down by one vehicle or the other. These are men and women who transform their bodies through healthy eating and dedication to physical fitness. They were obese, they adopted healthy choices, and they were also encouraged by their system, the system that they live in. And on the right-hand side, you can see that they are better off. This is another picture. They are healthier when they lose or shed fat. When they lose or shed weight, they are healthier and they are happier. What is the take-home message? The take-home message is that healthier children grow up to be healthier adults. A reduction in the incidence of childhood obesity is desirable. To curb the menace of childhood obesity, we need to make healthy choices, diet, physical activity. Reduction in the scourge of childhood obesity demands multi-sectoral actions, such as the implementation of policies that encourage healthier food options and improved health sector responses to identify and manage obesity, promotion of school health programs, and top on the list, political will. These are my references. I want to thank you all for your rapt attention. Thank you.
Thank you, Dr. Folakemi Rewole-Ojo, for the beautiful presentation. She has done a beautiful work talking to us on LD choices, LDR system, LDR lives. And thank you for saving us 5 minutes. We appreciate that. And I'm sure many people have questions at the end. So we'll wait till the very end to ask questions. So we'll be going into the second presentation by Dr. Kabiru Sada. I will encourage him to share his slide now, and he's taking the topic Changing System, LDR Lives. And Dr. Kabiru Sada is obtained his MBBS in 1999 and had his postgraduate fellowship at National Postgraduate Medical College in 2006. He had the fellowship of American College of Endocrinology in 2015. He's a member of so many professional bodies, including Nigeria Medical Association, Diabetes Association of Nigeria, American Association of Clinical Endocrinologists. He's a consultant physician and endocrinologist with FMC-SO since 2006. And he was also a visiting consultant, senior lecturer with Usman Fodio University Teaching Hospital and University from 2007 to 2013. His administrative roles included the Department of Medicine, FMC-GUSO from 2007 to 2010. He had been head of clinical services of FMC-GUSO from 2012 to 2015. He was also the chairman Nigeria Medical Association, Zamfara State from 2010 to 2012. He was also a board member of FMC-GUSO and FMC Castina from 2011 to 2023. He's also a member committee for establishing the College of Health Sciences, Federal University, GUSO from 2022 to 2024, and is a pioneer dean for Faculty of Clinical Sciences of Federal University of GUSO from 2024 to date. He has authored so many papers, more than 30, and his research interest is in diabetes, endocrinology, and hypertension. And he has offered so many community services. The coordinator of Diabetes Association of Nigeria in Zamfara. Is also a regular contributor to health awareness program on radio and television in Zamfara State, and multiple awards. He has obtained multiple awards from Diabetes Association of Nigeria, ARD, MDCAN, and NMA so far. So thank you so much, Dr. Kabiru Sada. You have the floor. Please, you can go ahead and share your screen, and you have the next 15 minutes to present to us.
Hello, good afternoon, our section.
Good afternoon,
hello.
Sir. Yes, sir.
Kindly help me share the slides.
Oh, should I share from my own side?
Yes, share from your own side. The network here is not good.
Okay, let me look for your slide.
Thank you.
I hope this is your slide, sir. I think, yes, it's your slide.
Okay. Good afternoon, everybody, and welcome to World Obesity Day 2025. I am going to be presenting on changing diabetes. Changing this is commemorated every 4th of March, starting from year 2020, that's 5 years ago. And the whole essence is to enlighten the community on the risks associated with obesity. Next slide. Hello, next slide. Hello, our section. Hello. Hello. Section.
Good evening, sir. I think his network went off. He will be with us
Yes.
shortly.
Okay, it's the network.
Yes,
I'm
sir.
even trying to see if I can share from my own side, but the network is fluctuating. Okay, wait, please. I will share from my side. Okay, fine. Okay, sorry for the delay. Every 4th of November is commemorated as World Obesity Day to highlight the risks that are associated with obesity. The theme for this year is changing systems, healthier lives.
Kabir, we cannot see your slides.
We can't see your slides, sir.
We are seeing your desktop. We are seeing your desktop.
Hello, sir. So I will start sharing the slides now, sir.
Okay, I see my desktop. Okay.
Yes.
Hello? Hello?
Yes, Dr. Sada, we can see your slide now.
You can see my slide now?
Yes.
Okay, fine. Sorry for the delay. So the theme for this year is changing system, healthier lives. We'll discuss under this outline. Obesity is a state of excess adipose tissue that affects health adversely. Sometimes it is being, weight is not the same as obesity. Some people can have lean body weight and still they are not obese. But WHO classify obesity as BMI greater than 30%, but 30 kilogram per meter square. But some can have a BMI more than 30 kilogram per meter square because of lean body mass and they are not obese. Obesity is a major risk factor for diabetes mellitus and cardiovascular diseases, and it reduces life expectancy by 5 to 20 years, depending on the severity of the obesity. In terms of epidemiology, the prevalence of obesity globally has tripled since 1975, and over 1 billion people are obese, including 650 million adults, 340 million children, adolescents, and 39 million children. The country that has the highest prevalence of obesity is American Samoa. That is an island. Then in terms of a big country, United States has the highest obesity rate, around 36%, followed by Canada, Mexico, and United Kingdom. About 13% of adults are obese worldwide, and 18% of children are also obese. In Nigeria, prevalence of obesity is increasing, especially because of changing lifestyles and urbanization. A study by our teacher, Propupet et al. In about 20 years ago, found that the prevalence rate of obesity in Jos was around 4.2%. But 5 years ago, Dr. Chukwuonye and Ezeani conducted a full prevalence, and they found that obesity in Nigeria is up to 10.9%, a rapid increase. And this obesity is commoner among females compared to males. The highest region with obesity in Nigeria is South-South. It's not surprising. They also have the highest prevalence of diabetes mellitus from a full prevalence by our president. And the lowest prevalence is in the Southeast. There are different methods of measuring obesity, but the worldwide, globally accepted one is the body mass index. A body mass index greater than 30 kilograms per meter square can be described as obesity. But we have earlier mentioned the shortcoming, those that have lean body mass. In South, those of Indian descent and Japanese descent, WHO has given a lower cutoff for them, around 27 kg per meter square, because they develop complications of obesity before reaching 30 kilograms per meter square. Waist circumference is an important marker of obesity. More than 102 centimeters in men and more than 88 centimeters in women is in support of obesity. Generally, we have two types of obesities: the apple shape, that's the abdominal obesity, and the pear-shaped obesity, the obesity found in the feminine type of obesity. The android, that's the apple-shaped obesity, usually tend to cause more cardiovascular risks compared to the gynecoid obesity. Waist-hip ratio can also be used to assess obesity. Then neck circumference is also an important marker of obesity. Males that have about 15.4 inches of their neck circumference around the neck circumference is a pointer to obesity, while females that have a neck circumference of around 4 inches is also in support of obesity. The best way to assess obesity is by taking body part percentage using dual energy X-ray absorptiometry or electrical impedance, which is just mostly used for experimental purpose. If the body mass percentage is more than 25% in males, they can be described as obese. If it is more than 32% in females, they can be described as obese. Pathogenesis of obesity is dependent on the genetic factor, behavioral factors, and environmental factors. I believe the pediatric endocrinologist has discussed about the genetic factors, such as Prader-Willi syndrome. Then the diet and lifestyle. Those that take high calorie and are less active are more likely to have obesity. Then hormonal and metabolic factors like insulin resistance, leptin receptor dysfunction, all lead to obesity. Then socioeconomic class and environmental factors. It's found that in many societies, those at higher socioeconomic class tend to have more obesity than those in lower socioeconomic class, especially in Africa. There are some hormones that play a great role in pathogenesis of obesity, like hormones and some peptides like leptin and melanocortin peptide. These ones tend to suppress appetite. So in humans, it's found that those that are obese, they have high leptin, but the problem is that they have receptor defects. So the leptin is raised, but it's not suppressing the appetite. Another peptide that play a role in obesity is ghrelin. Ghrelin is created by small intestine, just like our incretins. So this ghrelin stimulates appetite and is found to be elevated in Prader-Willi syndrome. Neuropeptide Y is also a peptide that stimulates appetite. Adipose tissue can be described as an endocrine organ. That's why obese people tend to have a lot of cardiometabolic derangements. Adipose tissue secretes leptin, it secretes adenopectin. The leptin that is secreted by the adipose tissue tend to be ineffective because of leptin resistance in obese individuals. And the adenopectin that improve insulin sensitivity tend to be reduced in those that have obesity. This adipose tissue also release tumor necrosis factor alpha, interleukins, and metalloproteinases. These metalloproteinases play a role in cartilage damage. That is why, apart from weight bearing, those that are obese tend to have a lot of osteoarthritis. The fat tissue, the adipose tissue, also release angiotensinogen plasma activator inhibitor, which all play a role in cardiovascular diseases. Obesity causes a lot of complications. It has been established that those that have body mass index greater than 40 tend to have 5.5-fold risk of hypertension. And they tend to have 18-fold risk of diabetes mellitus and insulin resistance among males, and 13%-fold risk of among females. They tend to have increased cholelithiasis, obstructive sleep apnea, varicose veins. They tend to have tinea intertrigo, osteoarthritis. In some societies where obesity is discouraged, they tend to have depression and low self-esteem due to social stigma. But in Africa, especially Nigeria, at times we consider obesity as an evidence of good living. Those with obesity are at increased risk of colorectal carcinoma, endometrial carcinoma, and pancreatic cancer. However, obesity protects against osteoporosis, just like the way cigarette smoking protects against Parkinson's disease. Obesity can be managed by lifestyle intervention, such as dietary changes and physical activity. As much as possible, we should return to our natural foods, plant-based food. We should avoid the fast food of Western culture. And individuals should be encouraged to exercise. Then medical interventions, the weight loss medications such as Orlistat, glucagon-like peptide receptor agonists like liraglutide, semaglutide, different types. Then sibutramine, pentamine. My colleague will discuss more on the pharmacological treatment. There is role for bariatric surgery in those that have a BMI more than 35 kilograms per meter square. And the bariatric surgery mostly done is gastric bypass or sleep gastrectomy. Actually, after bariatric surgery, a lot of patients get better and all the complications of obesity tend to resolve. So it also has its own complications. Then individuals should have behavioral therapy on how to reduce food intake and to exercise to achieve long-term weight management. Weight reduction has been found to be very beneficial. In fact, it has been established that those that lose 10 to 15% of their initial body weight can have reversal of their type 2 diabetes mellitus. Those that lose 5 kilograms of their original weight can have the risk of them developing type 2 DM. And 1 kilogram weight reduction is accompanied by around 2 millimeters of mercury decrease in blood pressure. And they tend to have improvement in osteoarthritis and sleep apnea. It's been established that when an obese individual lose around 9 kg of his original body weight, they tend to have 53% reduction in cancer-related death. And intentional weight loss has been found to reduce premature deaths by 15 to 30%. So weight reduction is highly beneficial. When you lose weight, you gain life. How do we prevent obesity? Healthy diet, more of fruit-based diets, public health policies like sugar tax. Sugar tax was imposed in Nigeria to companies that supply beverages, but it has been reversed recently. These foods should be well labeled so that we can know their calories. There should be health education in schools. We should educate our children to know how to exercise in early life, because when they know the benefit of exercise, they are likely to continue in adulthood. Also, in workplaces, we should encourage exercises. I don't know if our hospitals are still having football pitches and other sporting facilities. We should encourage that. Of recent, I have seen some hospitals that are encouraging weekly exercises. So we should extend it to the general public. Then we should encourage walkable cities. When roads are to be constructed, we should find a way of advising government to ensure that there are places for pedestrians where people can exercise. And then the challenge now is only the walkable cities, even security. We have to ensure security. Most people exercise early in the morning or at night. So if there is insecurity, you find it difficult for people to go for outdoor exercises. The recommendation for exercise is at least 150 minutes of exercise per week. It has been established that those that use step counters like pedometers, on the average, they tend to increase their steps per day to 2,000 to 2,500 steps additional per day because of motivation by the step counter. So, and it's a good way of measuring whether especially our patients, whether they are exercising regularly or they are not exercising. And it has been found that those that use step counter, when they increase the exercise rate, they also have accompanying decrease in body weight by around 0.38 kilograms per month. So now to the theme for this year's World Obesity Day. The essence of this theme is to actually not to blame the people that are obese, but to make advocacy to government so that policies can be changed. Governmental policies involve policy on health, on food system, on media, and the environment. So for the health system, health workers need to actually have more pay more attention on obesity and advise people on how to shed weight. Instead of treating the chronic diseases, it's better to focus attention on how to address the basic problem that cause the chronic diseases like hypertension, cardiovascular diseases, and type 2 diabetes mellitus. So this obesity management should be integrated into primary health care, but in Nigeria, a lot of our primary health cares are not functioning. And then we need to train a lot of the workforce on the complications of obesity so that they can advise people. They can advise their clients. On food system, this tax on sugar sweetened drinks, but it was withdrawn. We should discourage people on taking these energy drinks. In northern Nigeria now, a lot of people are taking energy drinks that have a lot of calorie and a lot of sugar. This should be discouraged. And for products that are unhealthy, as much as possible, we should discourage advertisement. And then we should encourage formulation of food products that are healthier, that are low in calorie, low in sugar content. For the environment, we should encourage walkable cities, that is pathways for pedestrians. We should encourage cycling. Actually, when we look at it, a lot of our people, they use motorbikes, they use cars up to their garage. Unlike in developed countries where they use public transportation. At times when they drop in a train, they walk for a long distance before they reach their houses. So that's adequate exercise. So here, like, we should encourage our working environment. People can park very far and trek to their offices instead of parking very close to their departments. And for places that are upstairs, we should encourage people to climb stairs rather than to enter lifts. I know there are some companies that institute policies during resumption time. They don't own their lifts. They leave the lifts for visitors so that people, their personnel can exercise. We should encourage the media to actually do a lot of health education on obesity. In conclusion, I want to draw our attention as healthcare providers that as much as possible, we should educate the general public that obesity is not a good sign of living. It comes with its own complications. And we should encourage that our society, our people in our society should be taking food that are as natural as possible. A lot of vegetables, a lot of fruits. We should encourage health education, especially sports in schools. When children know how to play sports early in life, in adulthood, they will continue. The prevalence of obesity in children now is 18%. In adults is 10%. It's the children that will become adults. So if care is not taken, this 18% of children that are obese will increase our proportion of adults that have obesity. But I know a lot of schools now, they don't have place for sports. A lot of schools now is reading. No time for physical and health education like the time we were young. So these schools should be encouraged to ensure physical and health education and practice of that health education. Weight control.
Thank you, Dr. Kabir Sada, for the presentation on changing system elder lives I want to appreciate you for keeping to time. So we'll be going to the third presentation, which is the final presentation for this evening. And that will be by Dr. Anthony Anyanwu. We'll be talking about obesity, the latest advances in anti-diabetes, the latest advances in anti-obesity pharmacotherapy. I'll encourage Dr. Anyanwu to start sharing a slide right away. While sharing a slide, I will take a short citation on Dr. Anyanwu. Dr. Anyanwu Anthony Chinedu graduated as a medical doctor with honors from the prestigious College of Medicine, University of Nigeria-EMSON. He had his residency training at Lagos University Teaching Hospital, Idiaraba, Lagos, and holds a master's degree in pharmacology and therapeutics, University of Lagos. He's a consultant physician, endocrinologist, and diabetologist at Federal Teaching Hospital, FMT Owerri, formerly FMC Owerri. He was a former personal physician to the governor of Imo State and immediate past director of training and research, FTH Owerri. He's a senior lecturer at the College of Medicine, Federal University of Technology Owerri, Futo, and the current chairman of Diabetes Association of Nigeria, DAN, in Imo State. Dr. Anyanwu is happily married and blessed with beautiful children. He's a good footballer and holds the championship flag as the best table tennis player at both NMA and MD-CAN in Imo State. Thank you so much, Dr. Anyanwu. You have the floor. Please go ahead and start your presentation within the next 15 minutes. Dr. Anyanwu.
Right. Good afternoon, everyone. Hope I can be heard.
Yes, we are hearing you now. But we're not seeing your slide yet. You're not sharing your slides yet.
Yeah, I'm trying to do that.
Okay.
Okay, can you see my slide?
Not yet. We're seeing your folder. So folder we're seeing, you're sharing your folder instead.
It's actually telling me that I'm sharing my screen.
I'm not seeing, you're sharing your screen, but it's not the slide you're sharing.
Okay.
So maybe you should stop sharing and click on your PowerPoint, your slides. Okay, we can see your slide now.
Okay, good. Right. Sorry for that hitch. Good afternoon, senior colleagues and colleagues. And thanks, Dr. Olopade, for that introduction. Let me quickly appreciate the EMSON executives and the LOC for this privilege to be among the speakers for today's event. My name is Dr. Anyanwu Anthony Chinedu. I'm a consultant endocrinologist with the Federal University Teaching Hospital, Owerri. I will be talking to us on the latest advancements in anti-obesity pharmacotherapy, and I'll be running through this discussion with this outline as my guide. This presentation intends to summarize the current knowledge on obesity, pathophysiology, and the approved anti-obesity pharmacotherapy. According to the World Health Organization, obesity is defined as an accumulation of excess body fats in such a manner that could impair the health of the individual. As mentioned by the previous presenters, obesity using the BMI could be defined as levels greater than or equal to 30 kilograms per meter squared, while overweight is defined as BMI between 25 to 29.9. We know obesity to be a complex polygenic disease that involves the interaction between environmental and multiple genetic factors. In simple terms, it may be seen as an imbalance between food intake and the energy expenditure over a long period. Most cases of obesity results from multiple gene defects. However, in very few cases, some obese individual may come down with obesity because of specific gene defects. And that is known as the monogenic forms of obesity. Examples include Prader-Willis syndrome, Cohen's-Armstrong syndrome, among others. The pathomechanisms of obesity. It's important to understand the pathophysiology of obesity. The reason being that the general mechanism of action of most anti-obesity medications targets the basic pathomechanics involved in obesity. There are three major regulatory pathways involved in obesity and energy balance. And that has to do with the central nervous system, as well as peripheral modulators of weight balance. In the central nervous system, we have certain neurons located in the arcuate nucleus of the hypothalamus. We also have the vagal afferents from the brain stems. And then lastly, we have the adipose tissue, as well as the GI tracts, known as the peripheral regulators. In the arcuate nucleus, we have the anorexic neurons responsible for loss of appetite and weight loss. The anorexic or anorexigenic neurons contain the pro-opiomelanocortin fibers, the cocaine and amphetamine regulated transcript peptides. Activation of this pathway results in loss of appetite. There are signals that can either directly stimulate or activate the pump-cut pathway or indirectly stimulate it. The direct stimulators include peptides such as leptin, while the indirect stimulators include molecules like serotonin, dopamine, noradrenaline. That goes to say that any drug that can directly stimulate the pump-cut pathway would lead to reduced appetite, increased energy expenditure, and eventually weight loss. We also have, beside it, the orexigenic neurons. These neurons contain neuropeptide Y and the agouti-related peptides. Stimulation of these neurons would lead to increased appetite, reduced energy expenditure, and weight gain. Prominent among the stimulators of the orexigenic neurons is ghrelin. And then we also have the endocannabinoid agonists, which can also stimulate the orexigenic nucleus. Then the peripheral stimulators, like I mentioned, include the adipose tissue, which secretes leptin. And as I mentioned, leptin is an anorexigenic peptide. that can promote loss of appetite and weight loss. Then from the GIT, we also have the peripheral regulators, such as the glucagon-like peptide 1, GIP, amylin, and polypeptides, which could also stimulate directly the pump-cat pathway, resulting in weight loss. Now, looking closely at these neurons, the pump or anorexigenic nucleus, here you can see the orexigenic nucleus. When pump is stimulated or when it is activated, it results in the production of ACTH and alpha melanocyte stimulating hormone. Alpha melanocyte stimulating hormone stimulates the melanocortin pathway, MC4, which is responsible for the action of reduced appetite as well as weight loss. While the agouti-related peptide nucleus, when stimulated, goes directly to cause increased appetite. Now look at there are feedback fibers. This is important. There are feedback fibers from the orexigenic neurons to the anorexigenic neurons. The importance of this is that when a subject loses weight, either through lifestyle modification, after some time, you discover that they can no longer lose weight more than certain rates. For instance, the person loses about 10 kg. After that, you are not able to lose further. It is an adaptation mechanism, a physiologic mechanism to prevent excessive weight loss. And that is done by this feedback fiber from the orexigenic neurons to the anorexigenic neurons. In the pharmacotherapy for obesity, if you stimulate the anorexigenic nucleus, you may not lose so much weight unless you also look for another molecule that can help in preventing this inhibition. If you can inhibit this and then stimulate the anorexic neurons, you may have further weight loss. This slide just summarizes what I've said so far. We have the satiety neurons represented by pump and cats, and the green arrows shows those peptides or those factors that can stimulate loss of appetite. And then we also have the orexigenic nucleus, and the red arrow shows the peptides that can stimulate increased appetite and weight gain. Our focus today will be on the anorexigenic neurons responsible for loss of appetite and then weight loss. I talked about monogenic obesity resulting from defects in a single gene. For instance, defect in the pro-opiomelanocortin gene, defects in Kexin type 1 gene. Kexin type 1 produces the enzyme that clips pro-opiomelanocortin, splitting it into melanocyte stimulating hormone as well as ACTH. So if there's a problem with the production of this enzyme, it will affect the melanocortin pathway. Leptin receptor deficiency is another one. Leptin helps in reducing appetites, increase energy expenditure, and weight loss. So deficiency in leptin receptor will also cause obesity, this time monogenic obesity. This slide shows the various defects that may result in monogenic obesity. Okay, leptin deficiency, pump, not being able to be cleaved into melanocyte-stimulating hormone and ACTH if there's a defect in the KEXIN1 enzyme. The current anti-obesity molecules we have is based on single molecule drugs that act either by enhancing loss of appetite, inhibiting hunger, or triggering catabolism, that is resulting in increased energy metabolism. As with other chronic metabolic diseases, the initial management of overweight and obesity emphasize the use of lifestyle modification combined with the anti-obesity drugs. This is because from studies, we've seen that lifestyle intervention alone is not able to achieve long-term weight loss nor maintain weight loss in most individuals. What are the indications for anti-obesity pharmacotherapy? From the clinical practice guideline published by the Endocrine Society, is indicated in patients who fail to achieve clinically significant weight loss, defined as losing at least 5% of the baseline weight after 6 months of lifestyle interventions. Pharmacotherapy can be offered to those individuals if they are obese or overweight with at least one obesity-related comorbidity. And the obesity-related comorbidities include type 2 diabetes, cardiovascular diseases, hypertension, dyslipidemia, obstructive sleep apnea, non-alcoholic fatty liver disease, osteoarthritis, and certain malignancies such as endometrial, breast cancer, colon cancers. We have basic principles that should be observed before you institute anti-obesity pharmacotherapy. One of them is lifelong treatment. You should bear in mind that obesity is a chronic disease, and the treatment is intended to be lifelong, just like we treat other lifelong diseases such as diabetes and hypertension. And you should let the patients know that discontinuation of most of these anti-obesity drugs often leads to weight gain or weight regain. Secondly, anti-obesity medications, like I mentioned, targets the major pathophysiological pathways involved in obesity. Thirdly, anti-obesity medications do not just benefit weight reduction, it also affects other comorbidities and other metabolic parameters. For instance, most of the anti-obesity drugs also reduce blood sugar, improve dyslipidemia, and also reduce chronic inflammatory markers. Lastly, you should expect heterogeneity in weight loss response, meaning that just like every other medication, there are patients who may not respond at all to your treatments. And there are those that may respond even more than the figures we've gotten in most researches. The tortuous history or journey in search of a novel anti-obesity treatment can be summarized with the words of Georges Saturn. He said, and I quote, "When we say that science is essentially progressive, this does not mean that man, in his quest for truth, follows always the shortest paths. Far from it. He beats about the bush, does not find what he's looking for, but finds something else. He retraces his steps, loses himself in various detours, and finally, after many wanderings, touches the goal." In the last 100 years, efforts to deploy anti-obesity medications and treatments were repeatedly tried and failed until we got to where we are today. This is the story of anti-obesity medications, starting with thyroid hormones, dinitrophenols, which were produced in the 1892 and 1933, early 1930s. Both thyroid hormone and dinitrophenols are performed by thermogenesis, causing uncoupling of oxidative phosphorylations in such a way that heat is produced instead of ATP. And for those drugs, the side effects were so much that they had to be withdrawn from use as an anti-obesity drugs. Prominent among these in 1941 was the rainbow pills. This was more like concoction, where you have amphetamine, thyroid hormone, digitalis, diuretics, barbiturates, all combined in one. It was discontinued also because of increase in anxiety and deaths. If you follow all this, you get to the 1999, where we have Olistat was discovered, is still currently in use. Locaserin, that was produced in 2012, was also discontinued in 2020 due to increased risk of cancer. Rimonabant, most of us know this drug that was produced in 2006, an endocannabinoid inhibitor. It was so good and hopeful. However, in 2009, it was discontinued or banned because of suicidal thoughts, increased depression. All through 2023, 2021, we have semaglutide. 2023, we have tirzepatide. I'm going to talk about all this. This is just to tell us a brief history of anti-obesity pharmacotherapy. The classes of the FDA-approved anti-obesity medications, we have sympathomimetic agents. Example is phentermine. We have dual agents, combination of two drugs. Lipase inhibitors, example, Olistat. We have the incretins, liraglutide, semaglutide, and emerging agent. There's a single agent with dual agonists. Phentermine was approved in 1959. Is among the first approved short-term medications used for obesity. Can use phentermine in treating obesity within 3 to 6 months. Not good for long-term because of side effects. The mechanism of action, phentermine increases noradrenaline. Like I mentioned in the pathophysiology of obesity, drugs that increase sympathomimetics such as noradrenaline, dopamine, serotonin are anorexigenic agents. The drug is cheap, and the side effects include increase in blood pressure and pulse, sleeplessness, constipation, dry mouth, and arrhythmias in some patients. Olistat is very common to us, approved in 1999 for adults and adolescents obesity, ages between 12 and 16. Olistat promotes weight loss by inhibiting gastrointestinal lipases, both the gastric and pancreatic lipases, thereby decreasing absorption of fats from the GI tract. From trials, Olistat is able to reduce weight compared to placebo. The difference between the treatment group and placebo was 3.8%. And is able to achieve at least 5% weight loss in 50.5% of the patients compared to placebo 30.7%. On the average, when you give 120 milligrams of Olistat, TDS, in a patient, it decreases fat absorption by about 30%. And it's been found to be more effective in digesting of solid fats compared to liquid fats. It has good effect on metabolic profile as it can improve insulin sensitivity and lower serum glucose levels. The side effects are those of fecal urgency, passage of oily stool, flatus discharge, which are the main reasons for discontinuation of this drug by most patients. However, it's been shown that with time, as you continue to take the medication, these side effects reduce. Olistat may reduce the absorption of fat-soluble vitamins, the ADEC vitamins. So it is recommended that while patients are placed on Olistat, you may need to give vitamin supplementation to prevent the loss of these vitamins. Phentermine topiramate, approved. This combination was approved in 2012. Topiramate, as we know, is a drug used for epilepsy and the prophylaxis of migraine. It blocks sodium channel and modulates GABA receptor and is able to stimulate the melanocortin pathway, causing loss of appetite and reducing weight. Several studies, which I summarize here, in the EQUIP, CONQUER, SEQUEL trials, this combination is able to reduce weight by 8.6%, the difference between interventional group and the placebo group. And at least 5% weight loss was achieved in the intervention group in 70% compared to 21% in the placebo group. Apart from the effect on weight, is able to reduce blood pressure, lipids, and then blood sugar levels in the patients. The side effects can be extrapolated from the sympathomimetic effects of phentermine, such as mental sedation, and also the effects of topiramates, mental sedation for topiramates, and then the sympathomimetic side effects as mentioned for phentermine above.
Dr. Anyanwu, your time is, you overshot the time by 7 minutes. So can you quickly round up in the next 5 minutes?
Right, I'll do that. Bupropion and naltrexone is another combination. Bupropion is a reuptake inhibitor of norepinephrine and dopamine. Therefore, it promotes the activation of the melanocortin pathway, while naltrexone, like I mentioned, is able to inhibit this inhibitory fiber from the orexigenic pathway, such that weight loss is more pronounced in such patients.
Sorry, Dr. Anyanwu, you've far exceeded the allotted time now. Can you round up in 5 minutes?
I'm sure we know liraglutide used in the treatment of diabetes. The dose for the one used in diabetes is far less than the one for weight loss, 3 milligrams. Let me quickly mention Gelesis 100. It's a hydrogel matrix composed of modified cellulose cross-linked with citric acid. Its mechanism of action is to absorb water in the stomach and thereby promoting fullness. It achieved its primary intended purpose through a mechanical mode, so most times it is referred to as a device rather than a drug. Sex melanotides is approved in 2020 specifically for monogenic obesity. Sex melanotide is able to bypass all the defects mentioned in monogenic obesity. It directly stimulates melanocortin-4 receptor. That way, it helps in decreased appetite and weight loss. And lastly, we have tirzepatide among the approved drugs. This is the newest of them all. It's first-in-class dual agonists at the GLP as well as GIP receptors. So it has a more pronounced effect on weight loss, while others have weight loss less than 15% body weight. It is only tirzepatide that is able to achieve a weight loss of over 20% compared to others. These are the off-label anti-obesity drugs, which most of us know, but they are not approved. The future directions for anti-obesity is focused on multi-target strategies. For example, we have drugs that have one particular drug that have triple agonist action for GLP-1, GIP, as well as glucagon receptor. From study, this drug is able to give us a weight loss average of about 24%. So this is very good. And we also have another combination of semaglutide with amylin coming up. And lastly, we have anti-obesity vaccines, vaccine against ghrelin, somatostatin, and adenovirus 36, which is known to cause, associated with obesity. These are my references.
Thank you, Dr. Anyang, for the beautiful and extensive presentation. Thank you so much. This is highly stuffy. Let me just say so. So this is opportunity for us to ask questions. So if you have questions, kindly raise your electronic hand. I will want to hand over to the chairman, Professor Babatope Kolawole, to handle this session for us.
Thank you very much, Dr. Olopade, SG. Just as you said, the options available to us is we can electronically raise our hands, or we can just type our questions directly in the chat box, whichever one suits us. So Dr. Rewale Ojo presented, Dito Kabiru Sada, and now Dr. Anthony Anyawu. So let us know who you are directing your questions to. Thank you.
Dr. Adetuji is raising his answer.
Dr. Adetuji, you can unmute your microphone. And then...
Thank you very much, sir. Greetings to teachers and senior colleagues on the call. I want to congratulate all the three speakers for the very beautiful and well-researched presentation. I think this year's Obesity Day has been well celebrated, and I congratulate EMSON leadership for this initiative. Having said that, I have no question, but I have a piece of information that will be beneficial to all of us, particularly those of us in the southwest Nigeria. I'm happy to inform us that OATXC now offers bariatric surgery. We have recorded a good number of successes. I think in the last about 4 weeks ago, sleeve gastrectomy from a middle-aged woman who is diabetic, who was referred from our clinic to our surgeon colleagues, a laparoscopy surgeon, and the surgery went well. It was a sleeve gastrectomy. We intend to present this to the larger hospital community in due course. So this is just for the information of our colleagues, particularly those of us in the southwest. We have had up to 3 laparoscopic sleeve gastrectomy in OATXC Ilefe, and the outcome has been quite good. The latest one was actually a patient with comorbidity, and I can report that she did well post-op. We're hoping to follow her up in clinic. So this is just for our information. If we have patients that may benefit from this important modality in obesity care. Thank you once again for the opportunity, and I congratulate EMSON and the presenters for the beautiful presentation. Thank you.
Thank you very much, Dr. Adetuji, for letting us know of this. There's a question in the chat box. I don't know who this should go to, from Dr. Shile. Says he's noticed that fasting cuts down, his own weight faster than exercise. Dieting is also faster than exercise. Maybe Dr. Anyawu may want to speak to that. Do both act in concert? Or according to Collins Oshile's belief, fasting seems to be more effective than exercise. Dr. Anyawu, can you hear me?
Hello, Dr. Anyang.
Okay, maybe Kabiru can speak to that, if Dr. Anyawu is not with us. Dr. Sada.
Well, let me attempt that question from Dr. Oshile. Good observation. However, I'm not sure which one is best in terms of weight loss, either fasting or diets. However, we know that for dietary modifications, it's advised, what's important is caloric restriction. Okay, the reducing the amount of food or the portion of food the individual eats, and not just the quality. So depending on the amount of the reduction in somebody who is dieting, okay, the weight loss may not be that prominent. If you don't reduce maybe from 500 to 700 kilocalories from what the person eats initially. So, from research, I'm not too sure which one is better, either exercise or diet. But I think if you combine both of them, you may achieve a lot in terms of weight loss.
Thank you very much, Dr. Anyawu, for clarifying, providing clarification to Dr. Shile's concern about the place of exercise and fasting. Perhaps
Someone
also.
is raising his answer.
Oh, somebody's also okay. I will just like to speak about intermittent fast and all of those, the keto diet. But whichever way, I think both act in concert. So we really cannot practice one without the other. Both act in concert to achieve and maintain weight loss. Pharmacists can.
Okay, can I go ahead, sir?
Please, there's a pharmacist that I'm told has his hands up.
Yes, I have my hand up.
Okay, please speak.
Okay. Good evening, Mr. President, and everyone in this webinar. I want to congratulate EMSON for the successful commemoration of this year's World Obesity Day. I think it's really a very great one. I think during the presentation of Professor Sada and the first presenter, something came to me because I was looking at how could we address this problem. I mean, truth be told, obesity in Nigeria is a national pandemic, if I can put it that way, or an epidemic, if I can just put it that way, and it requires a dramatic action. And I'm just trying to identify at least 3 key stakeholders. I don't know who is right to engage them, whether it is EMSON, but I believe that EMSON can champion this engagement. The first one is the policy makers. What is the policy? What is the national policy or plan of action to control and prevent obesity? We have none, as far as I'm concerned. I know there is something inside the National NCD Control and Prevention Program or whatever, but it's just a minuscule part of it. It's not receiving so much of attention. Somebody needs to engage them so that we can have a policy framework that enables, right from the government at the national level down to the last tier of government, so that they can put budget behind it and drive it. I think that is number one. The number two is the regulators. The NAFDACs of this world, the Ministry of Health, and any other agency that are to regulate. And then the third one is the food industry. To me, I can almost say that there is a connivance, sorry to use that word, between the food industry and government, maybe because of the revenue that they generate from all this food industry. Regrettably, about 2 years ago, there was supposed to be a sugar tax on carbonated soft drinks, but there were a lot of political maneuverings and that thing never saw the light of the day. And by the way, the way it was supposed to be implemented was just to profit the government, not even the masses. You know, I think the food industry needs to be engaged. How can we reduce the sugar? How can we reduce all these calories that they are putting in it? All these noodles, I don't want to mention any specific product, but a lot needs to be done there. People have compared what is the food that we are served in Nigeria and those in advanced country. And there are a lot of difference. The one we have here are a lot unhealthy. And then the third stakeholder will be the general public. How do we raise nationwide awareness? And who is to champion this? I know it's just a food for thought. I don't know if who is best to address this, but it's just a food for thought that until we have that framework in place, it might just be difficult for us to move forward. Thank you very much.
Thank you so much, Dimeji. Excellent. Thank you. You couldn't have put it better.
Thank you.
The passion with which you spoke, it's acknowledged. And going forward, let me also reassure you that these are some of the discussions that are taking place within EMSON and the endocrinology societies. And this is also what led to us putting together this kind of event for this evening. Be assured that what you have said is well noted, and it will be taken further beyond this meeting. Thank you so much, Dimeji.
Thank you, sir. Thank you,
If we look at the chat box, okay, thank you very much, Professor Lamoyegun, for your contribution. Professor Lamoyegun saying dietary restrictions actually lead to more weight loss than exercise, though both work in concert. There's a question from Balarabe Abdulaziz. He says, let me ask, I think Anyawu is best positioned to take this. Any room for combination therapy for the OMs? And then is tirzepatide, is it available in our country? And then when will you intervene surgically? Dr. Anyawu, are you still with us? Combination therapy for the anti-obesity drugs. Do we combine medications, or do we just use single monotherapy?
Right. Thank you very much for those questions. For combination therapy, like I mentioned, is the way to go for anti-obesity pharmacotherapy because of the knowledge of the pathophysiology of obesity. I gave us some of the approved combinations currently. One of them is a combination of bupropion and naltrexone. We also have phentermine and topiramate. But research is ongoing for the combination of the GLP agonists with other agonists, such as GIP and glucagon receptor agonists. And then when to intervene for surgery, I told us that if we even start anti-obesity medications, we just have to try lifestyle modifications first for about 6 months. And if the person does not lose up to 5% of the baseline body weight, you commence anti-obesity pharmacotherapy. And if you use this for about 6 months, again, the anti-obesity pharmacotherapy, and the weight loss is not up to 5% of the baseline body weight, you start thinking of surgery, surgical intervention. Now, if you want to combine other anti-obesity drugs, that can be done off-label. Like I said, the ones approved are just those two I mentioned. So combining maybe GLP-1 with the off-label metformin for obesity, it's off-label, but it can be done. Thank you.
Thank you very much, Dr. Anyawu. And just to say that in a way itself, tirzepatide is also a form of combination because it targets both the GIP and the GLP-1 receptors. And then, of course, surgery too, at times, we take into consideration existing comorbidities and the severity of the obesity in recommending surgery. So thank you. Dr. Olopade, I hope we can still take one or two questions. Please confirm that we still have time for one or two questions.
You can still take one or two.
Okay. So there is a question here also from SG himself. Dr. Rewole Ojo and Sada will please respond to this. What recommendations will be made to change the systems driving obesity in Nigeria? I think this is very, very important. And I think this is also part of what Dimeji Agbalade was also addressing in his comments. Dr. Rewole Ojo first, and then Kabiru Sada. What will you recommend to make systemic change?
Thank you very much, sir, for the question. I amongst all the systems, I think the governmental system, that's the political will, is very important. A lot has been said about policies. So if I look at childhood obesity, I think the political system will affect the school health program, will affect the health system, and also the media. So what are the things that are put out? Like somebody talked about the highly, will I say, sugared drinks or meals that are not healthy. If the government is on our side and ensures that these policies are put in place, that means to discourage eating processed foods to the best of our abilities, and also to ensure that school health program is encouraged, then I believe that will reduce the scourge. If we, yes, I think the political will is very important amongst all the systems, the media, the environment. Yes.
Thank you very much, Dr. Rewole Ojo. I think so. In essence, you are suggesting policies targeted at agriculture, maybe providing subsidies for farmers to produce nutritious food so that it will be available to individuals, targeting the environment itself, targeting the educational system. It's a lot of work that needs to be done in that regard. Thank you so much. Dr. Sada.
Okay. Good evening, Mr. Chairman, our provost.
Thank you, sir.
Thank you, sir. So my suggestion is that the main challenge we are having in Nigeria is this issue of obesity is a sign of good living. We have to educate the public of the complications associated with obesity. And from what we can see now, a lot of children, about 18% of them are obese. So they will grow into adulthood. And sometimes a child who is obese will continue as obese in adulthood. So we have to change that notion. We have to deliberately create public health awareness using the media and also the government, and encourage sports. And another thing I feel, sir, in this Nigeria, we still have a lot of people that are underweight and that are food insecure. So statistics have shown that around 12% of Nigerians are underweight. So I will suggest those that have plenty, especially that South, Dr. Korubo axis, they should be looking at Northeast and other parts of the country so that there can be redistribution of resources. Thank you, sir.
Thank you very much. In fact, it's so interesting because I remember the work of Anas and Co, and I think you yourself, even in the Northwest, that was finding now increasing prevalence of waist circumference, central obesity, even in the Northwest, where traditionally people were slim. So a lot of, we are going through a lot of epidemiological transition and changes that this is perhaps the best time to nip these things in the bud. So thank you so much. Dr. Collins or Shile.
Dr. Denny is raising his hand.
Dr. Denny. Oh, okay. Dr. Denny, please, you have the mic.
Good evening, Mr. Chairman. Good evening, colleagues, ladies and gentlemen. I want to appreciate the three presenters. It's been quite illuminating. Mine is a comment, not really a question. I have listened to all contributions, but when we talk about government and this, yes, is the way to go in terms of policy. But I think we need to come lower down and try and use the media. When we talk about media, I'm not sure the modern media that we have now will do more. How many people are actually on social media? It's probably the elites and thereabout. But there is this agency of government, the National Orientation Agency. I think they are trying to wake up. Now they are putting the cartoons there to educate people on the need not to sabotage government effort. And I think this is the way to go. That body in the past can take message around the whole country in their vans, their buses, with their loudspeaker on top of it, talking in different languages that people can understand. And we need to pass this message down. The more this is done and people realize this, I think we will have moved forward, a step forward in reducing obesity. That is one. Two, the presentations did not address, or maybe I missed the part. What about the genetic obesity? Are they amenable to all these solutions we have prescribed? Because those are different things entirely. And those who have genetic obesity are most of the time frustrated when they are not losing weight. If any of the presenter can please address this on how to approach those with genetic obesity. Then the third one, the simple thing government will understand so that we start speaking in the language they actually will understand is to let them know. Let the government have policy in health, and there should also be health in policies. It goes hand in hand. So they want to make a policy, we want to build road. From the initial stage, a walkway must be there, a cycleway must be there, and everything has to be factored in before that contract is awarded. I think we start like this. Then the National Agency now comes in and tell us, oh, the likes of Dr. Denny and Olokwa, they don't need to bring their cars out. They should join the buses. Okay, we may complain that the buses are not too touch for now. Don't worry, our shed can get torn once in a while, but at the end of the day, we get the fine buses. And like we go to all these conferences, we know how we all work. And that is the way to go. National Orientation Agency, we need to get to talk to them, and they have things to develop. My small contribution, sir.
Thank you so much, Denny. Excellent thoughts. And I think you've also shed light on who we as EMSON, ASN, and Co. should be partnering with. We should find we already have a willing ally in the National Orientation Agency. And I think we should do all within our power to work with them to achieve this goal. You also spoke about creating walkways, government policies, and quote. That's very, very excellent. And I think on the lighter note, maybe we should begin with this proposed coastal road. Maybe if and Olopade will help us liaise with Ministry of Works so that they can put a walkway and you can walk all the way from Lagos to wherever the coastal road is terminating, maybe in Calabar or Port Harcourt.
In Calabar.
I have lost all my parts, sir.
So we are mandating. We are mandating the fair.
Interstate road, sir.
We are mandating the fair, and Olopade to help us work on that.
No, it has a cycle part already, and there is a train track.
Oh, excellent.
So as well.
Pardon me, Dr. Adetunji.
Dr. Olopade will not only lose weight, he will lose height.
No, but Chairman, the road already has a cycleway, and there's a train track. There's a train track for whatever.
That's good. Excellent.
It's just
Dr.
the walkway, I'm
Eziani
not
is
sure.
also saying that our food products should be properly labeled, detailing their sugar, fat, or salt content, and there should be a clear policy from government on this. I think that's good. That's true. But how many of our people can actually read these labels and interpret them properly? Even when we use it as exam material, we still, even those who are well read, still encounter challenges with interpreting food labels. So excellent contribution. Thank you so much. I don't know, Dr. Lakwade, is there anything I've missed?
Nothing,
The question? Sir. Okay. Thank you so much. So I think we've cleared all the questions in the chat box, and I don't know if there's still anybody with a burning concern before we call it a day. But I think at this juncture, it's important to again appreciate those who deemed it fit to put together an event of this magnitude, celebrating. Okay, I'm reminded of a question on genetic obesity, which I will like. I think Dr. Odeni asked that. I think somehow Dr. Anyanwu spoke about it, the monogenic obesities. Dr. Anyanwu, are you still there? Do you want to respond to that question by Dr. Odeni?
Yes,
Quickly,
sir. Yes. I spoke on monogenic obesity as those obesity conditions resulting from specific gene defects, genes that we could pinpoint. Yes, and I gave examples of those genes: the leptin gene, the pro-opiomelanocortin gene, and then the kexin-1 enzyme gene, and other examples like Prader-Willis and so on. And to treat such patients, you need genetic testing. You need to test to see that these individuals have these gene defects before you commence treatment. And the only therapy presently is the SET melanotide, which I mentioned, which is a melanocortin 4 agonist.
Thank you so much, Dr. Anyanwu. So it's left for
sir.
me to appreciate all our speakers, although I believe Dr. Professor Lamoyigun will still do that formally. But we've learned a lot. There's been a lot of discussion. But I think even more importantly, this evening, we've been able to come up with so many ideas on the way forward for obesity. And at this juncture, I think it will be best for us as an association, having initiated this, to then take the message forward. We are best positioned. It's likely all the agencies we've talked about, even including government, will listen to us if we can articulate these views in a way that is clear, understandable, and then we can make both government and society see the implications of not taming this obesity is a pandemic as it is presently. So we did that a nice evening, and it's been time well spent on the call. So it's now left for me to invite Professor Lamoyigun to do a formal vote of thanks, and then we can bring the meeting to a close. Thank you so much, everyone. Professor Lamoyigun, over to you.
So good evening, everyone. And let me especially thank the chairman of this occasion, that's Professor Babatope Kolawole, for anchoring the program. Thank you very much for providing the leadership. And then we also want to appreciate our speakers. They've taught us from their wealth of experience. From Dr. Folake Miriwale-Ojo, thank you very much for your presentation. Dr. Kabiru Sada Bello, thank you very much. And Dr. Anthony Anyanwu, thank you, Father, for your presentation. We've really enjoyed your presentation today. And we just hope that when we call on you the next time, you'll make yourself available. We also want to appreciate everyone who has joined the presentation today. I'm sure we have gained one or two things, and together we can stem the tide of obesity or rising obesity in Nigeria. And from what we have said, the president has just posted something, and that's all of our views will be harvested, and we are going to make it as a policy statement that will be sent to the relevant government agencies, and they will pick it from there. Let me appreciate my president, Professor Oloko, and then our able Secretary General, Dr. Oluwarotimi Olopade, for putting up this wonderful program. And this is just the beginning. And when we came on board, we did say that endocrinology is not just for diabetes, that we are ready to navigate to other aspects of endocrinology: thyroid, obesity, dyslipidemia, adrenal, reproductive endocrinology, and the rest. So very soon, we are going to get another presentation. I'm sure we've had a wonderful evening. Thank you very much for sparing your evening time to participate in this program. Thank you, and God bless you. Dr. Lopade, over to you.
Thank you. I have nothing else to say. Thank you to everyone for coming. Those who are full members of EMSON and those who are invited, thank you for finding time to join us. See you next time. Have a lovely evening.
Thank you so much. Thank you.
And you can listen to
Bye.
you can listen to the recording. You can go to our YouTube channel and Endocrine Metabolism Society of Nigeria to listen to this presentation again.
Thank you. Bye-bye.
Bye.
Bye. So.